And this is our team that did it. The third case study is one that I'm really passionate about right now, and it's very relevant because in 2013, Medicare will stop paying for 30-day readmission rates for heart failure. So if you have a patient who's been in your hospital and 2 weeks later, 3 weeks later, they're readmitted for heart failure, Medicare will not pay hospitals for that care. So our problem was heart failure patients are readmitted to the hospital at a rate of 22.6%. The goal was reducing the readmission rate for Medicare patients at 30 days by 30%. So the improvement we made were really improving communication and collaboration within the multidisciplinary teams. And it led to many changes. What it did was it simplified the pre and the post-discharge processes. So we have many processes we have to go to make sure that we first admit patients correctly to the hospital and know everything about you, from what medications you're currently on to what allergies you have. And then in discharging, we have to make sure that you know the medications you're going home on. Do you have to go home with any services like home health care? We eliminated waste in the system as streamlining the care of the patient through the system, thereby also reducing costs, and major improved communications among the entire team. So the staff from the inpatient side, the doctors, the nurse practitioners, home health agencies, our skilled nursing facilities, which are not part of our hospital or health system, they're separate entities. And it led to much better outcomes for patients. So our results, our 30-day readmission rate, our goal was to get to 16%. In 2009, we were at a rate of 24.4%, so we actually had gone up from a base period of 22.6% that we measured. We dropped that in 2010 to 18.6%, and for the 4 months so far this year, we're at 11.6%. And we're hoping we can get below 10%. It's taken a major amount of work from a lot of people to coordinate the care and educate our patients to get to that rate. We also measure 90-day readmission rates, and we're at 25.7% there. We've improved the number of patients we refer for home care from 51% to 73%. That's been a key part of keeping patients out of the hospital. And we've scheduled follow-up appointments. So some of the learnings we had along the way was that we had to make sure that within the first week patients were discharged from the hospital, that they had a follow-up appointment with either their primary care physician, their cardiologist, or a nurse practitioner. So I'd like to tell you about a patient. Mrs. G. Mrs. G was admitted to the hospital for heart failure. Our nurse coordinator went in to meet with her and her husband to begin heart failure teaching. Before they could do the heart failure teaching, Mr. G wanted to tell the nurse their love story. And so he went on to talk about how they had met at a street fair in one of our local communities, how he heard her speaking Italian and it caught his ear and he turned his head and it was love at first sight. And in the middle of telling the story, he broke out into an Italian love song he sang to his wife. Well, they were then finally able to begin to do their discharge teaching with her. She subsequently was admitted 3 more times, and so 4 admissions in 4 months. By the 4th admission, now our nurse coordinators knew both Mr. and Mrs. G, and they said Mr. G was looking very, very tired. He was her primary caregiver. And they convinced the cardiology team to invite what we call our palliative care team. Our palliative care team is a group, physician, social worker, chaplaincy, that actually can begin to have discussions with patients about goals of care. What do you wish for your care? You know, what do you want to happen? So the team came in, and Mrs. G was not interested in speaking with them, but Mr. G was. So the team sat down with Mr. G, and the first question that Dr. Pantalad asked Mr. G was, what is the worst thing for your wife about having to come back to the hospital? And he said, she hates the ambulance ride. She hates the ambulance ride, and she hates the fact that she's coming back to the hospital. And Dr. Pantalad told him, he said, we can help you with that. And they said the tears were streaming down his face because she didn't want to be in the hospital. She wanted to be home. Well, that team worked with her. They put things in place. They put hospice in place so she could go home. She stayed home with her family for 13 months. In our past system, that wouldn't have happened. She would have been back in the hospital and back in the hospital. She came back in 13 months later. She went to our Comfort Care Suites, which is a beautiful place we have that patients can go to die. And at that place, she was very comfortable. Her family was able to be with her, and she did pass away. In our past situation, she would have come in through the emergency department. She probably would have ended up in an intensive care unit. She could have then ended up with tubes and lines, and not really what was the best for her, and it would have cost a lot of money. So the cost savings for this that's what I wish for our patients and the improvements that we have in our heart failure readmission program. We also have improvements in care that will help heart failure patients who are eligible for advanced therapies also receive those therapies. The cost savings to the UCSF Medical Center were about $400,000. The estimated cost savings to Medicare, so funds that Medicare would have had to pay UCSF because she had been, our heart failure patients and Mrs. G, one of them, were readmitted, would have been about $1 million. So it was about 40 patients a year, and in 40 patients, we saved Medicare $1 million. It's a 16% 30-day readmission rate. So we're looking at major opportunities across the country. If you extrapolate $1 million for one medical center with the volume of heart failure patients we see, you begin to talk about billions when you include 3,600 hospitals across the country. So I hope that I've been able to demonstrate that it is possible to employ Lean Six Sigma in healthcare and improve the care and the outcomes for patients. Thank you. Thanks.